Bismillahirrahmanirrahim. Hi everyone. In a previous video I posted my YouTube channel under the POCUS series. I was talking about how POCUS can be useful in making the diagnosis of pericardial tamponade, and in that video I was referring to the European Society of Cardiology, the ACC diagnostic criteria for acute pericarditis, and at that time they said 2 out of 4 criteria can make the diagnosis of acute pericarditis. And I was talking about the physical exam finding of the pericardial friction rub, which is really hard to find, and how POCUS can be helpful in identifying new or worsening pericardial effusion. Now, this video is just regarding a new update by the American College of Cardiology. They just released an expert statement on the diagnosis and management of pericarditis. This is just released this month, a couple of weeks ago. So I thought to make this video to kind of get you guys updated on it, because I really kind of finding it really interesting that they added a couple of things here. So what's the new criteria that they put in their expert assessor statement? So the first criteria that they said must be present is a pruritic chest pain or any equivalent suggestive clinical presentations. Sometimes patient might have an element of, in addition to the pericarditis, maybe myocarditis, like perimyocarditis or myopericarditis, depending on which one seems to play more pathology. So in any case, they have to be something that's very suggestive of a symptom that's very suggestive of pericarditis chest pain, which is usually recisternal, which is usually pruritic, meaning it's worse with inspiration or worse with coughing or anything that's kind of irritates the pericardium. So this criteria must be present, and then you need, for definitive diagnosis, you need at least 2 of these coming 5 criteria. If you have only one, this is possible acute pericarditis. If you don't have any other criteria, this is unlikely to be acute pericarditis or pericarditis presentation. So what are these 5 criteria? Some of them are the part of the old criteria, the pericardial friction rub, which again is probably the hardest to find, especially with those without expertise. And the second one is ECG changes, which is usually described as the diffuse ST elevation and or PR segment depression. These are the classic ones. The new one, the 2 new criteria is inflammatory biomarkers being high. This used to be suggestive, but now they're included in the criteria. So high CRP, high ESR. So you probably need to order those tests if you're suspecting acute pericarditis if the other criteria are not met. So elevation of inflammatory biomarkers is found in about 80 to 90%. That's the inflammatory phenotype, and these sometimes can be associated with fever and or leukocytosis. But remember that in about 10% of patients, those are in the non-inflammatory phenotype or with the non-inflammatory phenotype. These patients, CRP or ESR can be low or near normal, and this is usually associated with the autoimmune conditions causing autoimmune pericarditis. So this is one of the new criteria. Another criteria, which is part of the old criteria, is finding new or worsening pericardial effusion, and this is where it can be helpful if you can detect that on the bedside, or you can see it in other imaging, especially echo, which is the most commonly ordered test in that purpose. And then the other new criteria is finding an pericardial inflammation, especially through cardiac MRI, where you can find enhancement of the pericardium and or edema. CT scan with contrast could be an alternative too. Now, you don't need to order cardiac MRI or CT with contrast, cardiac CT with contrast for any patient with suspected pericarditis. Obviously, if you have met the other criteria, then you're ready to go and start the treatment and looking for a cause. But in certain cases, the consensus suggests that this test might be useful. These patients include complicated cases, or patient with persistent pericarditis, or patient with recurrent pericarditis, or chronic pericarditis. So it's a little bit complicated picture. When the diagnosis is uncertain, and then you can look for pericardial inflammation through cardiac MRI or CT scan to help you in making the diagnosis. Patients who do not respond to standard first-line therapies, which are usually the aspirin or NSAID plus colchicine, and or in whom escalation of therapies is planned. There's other immunotherapy that could be suggestive to treat pericarditis. So if the patient is not responding to the simple ones, then and you need to consider other more advanced therapies, then maybe adding this test could be useful. And then lastly, patient with suspected pericardial complications like complex effusions and or constrictive pathophysiology. So these are the new criteria. I thought it's kind of interesting, and I thought to share them with you, and I hope that you find them useful. All right, thank you. See you in another video.